to study for ACLS because you got your notes and your book to use. But a lot of it in there, you're already going to have been tested on, you know, with your dysrhythmias and with this and stuff. So actually, this test would be after ACLS, right? On the calendar that. But that's all right. Okay, so cardiac emergencies. Oops. So we're going to talk about cardiac arrest, what we do in it, the equipment, the stressors to the family. So sudden cardiac death, sudden unexpected death caused by the loss of the heart function. Largest cause of natural death in the United States. It's way over 325,000 each year. Now there's different reasons for this. Some of it, yeah, that's what. Got my papers out of order. I'm like, wait a minute, that's not it. So sudden arrhythmic death, VFib, myocardial failure. They've had an acute MI. Structural abnormalities. We'll get into that, you know, when we talk about cardiogenic shock. Okay. Here's the cause. Okay. So they're not always cardiac, right? So it could be cardiac heart disease, myocardial hypertrophy, reperfusion following ischemia. So, you know, when your patients had the MI and now they're reperfusing, but something's not right there. Cardiomyopathy. Valve disorders. Aneurysm. Cardiac drug toxicity. Now, it could be non-cardiac. It could be a PE. They could have cerebral hemorrhage. They could be choking, right? So there's all kinds of reasons that they're having sudden cardiac death. And your book talks really good about this stuff, so make sure you do your reading on that. So what is a cardiac emergency? Anything that causes severe decrease in cardiac output, right? We know all about decreased cardiac output. When that happens, it leads to decreased circulation in vital organs, which leads to death, right? So this is, you know, how we've said we want to catch them before they get to that point. So they may present with the hypertension, the chest pain, dysrhythmias. So immediately we try to not avoid delaying the treatment. We want to get things going right away. We just went over signs and symptoms. Same little guy there, all the pictures. You guys should know those. So they can also be in respiratory arrest, right? We don't touch this too much in ACLS, but you know, when you go through more training, you know, we do have scenarios in there for that. So always oxygen, right? Make sure that airway's good. Give them that ventilation. They may need suction. Maintain that airway. We went over the advanced airways. Mrs. Music did it, and I don't think I showed you the video on that yet, so we'll have that to go over. Don't hyperventilate. Talked about that, right? So they could be in respiratory arrest. So the only thing different is we're not doing the compressions, right? They still have their pulse, but they need that respiratory aid. It means for ACLS, respiratory arrest means patients' respirations are completely absent or inadequate to maintain what they need. So, I know one question in your ACLS is about the gastric inflation, I think, or it used to be, you know, too much causes the gastric inflation. So what's our goal of resuscitation? So not just to make sure they're still breathing, right? We make sure we get them back. We want to establish that circulation and respiration. Also preserve that function in those vital organs, right? You know, we'll talk, you know, how we talk debrief about the H&Ts, right? We want to know what happened, what can we do to make sure that these organs are going to function afterwards. Read this. Priorities for successful resuscitation. DFib within 2 minutes for VFib, right? Or pulseless VTAC. That's on your card. That's on your algorithm. Between now and next Thursday, look over those cards, get familiar. Because when you're that team leader, we expect you to be able to tell us. Once you tell us the rhythm, tell us what you're going to do because you're reading your card. Make sure the CPR is adequate, right? Push hard, push fast. Secure airway and oxygen. And are we giving them an epi? Are we doing pacemaker? So different code status, you'll hear the nurses, as they're going to lunch, they're telling the other nurse, okay, all my patients are full code, so they know something happens, code them, We used to have patients wear bracelets that's with DNR-CCs. On the units we're on, we don't see the DNR-CCs, we see DNR-CC-A. Mary, what's the difference in an A and a full code? Anybody know?
Once they have a cardiac arrest, you're not going to do compressions of the CCA, but you're going to do everything you can up until that point.
Right, and do everything until arrest, right. It used to be, when it was not on computer, when they would say they wanted to be DNR-CCA, they could say, I want drugs, but I don't want compressions. Well, they didn't realize, we can put the drugs in, but if you're not doing compressions, it's not getting moved in the body system, but to them, they felt like something was being done. Or they may say, I want compressions, but don't ventilate, but now it's mostly like you do what you can, but you don't actually put them through the whole code situation. So it may just be the breathing helping with that, or, DNR-CC, it's just comfort care. We don't do compressions. They may have oxygen, but you don't, really get aggressive with tubing them or anything like that. So you will see that more on other units than, they won't put them on telly, not supposed to. Oh, your mic didn't want to work. Okay, I wonder what happened to her. So as you work, you'll see, next time you're on the unit for clinical or whatever, check the code status. See what the code statuses are. I think they actually scan in these orders that they can check the things now. Depends on what hospital you're at, of what they want done. But so that's just different code status you will see. If you fill out your living will, power of attorney, you have the right to say what you want during this part. So, make sure whoever is you're speaking for you knows. Years ago in the unit, they had a young man, 22, I think he was in a car wreck. Well, his mom had been a drug user. He had been raised by his grandparents. Well, now that he was an adult, he could not make decisions. He was not conscious. It went to next of kin, which was his mom. So the grandparents had to get emergency guardianship. So, make sure you have somebody that will be able to speak for you if you're not able to. You just never know when it might be needed. So, okay. So the roles are in our, why do we do this? Better preparation and practice, improve prognosis. So do they have at Ohio Health, do they have code drills? We used to when I worked years ago, but especially on nights, they like to throw them out there.
We used to. We haven't had one in probably a year or more.
Okay, that's what I wondered. Especially the small hospitals like Shelby and stuff where they don't get that money. You've never been in one. Oh, really, Mary? I figured you had. A drill. Okay. So, yeah, they really should do them, in the outlying hospitals, because if they're new grad, and you've just done it in your ACLS now, but it's good to practice. So again, we don't really have a doctor in your ACLS mock code. We may this time. I don't know. We're going to have more than enough people. So you will be the team leader, the primary nurse. There will be a med nurse. Respiratory will be the bagging. Somebody's going to monitor the rhythms. You're going to switch off doing compressions. Somebody's going to record, of course. In the hospital, you may have unit clerks, aides that will be your gopher, go get stuff you need. I know at Mansfield Pharmacy's there 24/7. Now Shelby Pharmacy leaves, so it's up to you to get those things out of the cart. Okay, so it just depends where you work, who you have to help you with that code. again, when we find the code, we want to make sure it's a true arrest, right? This is where I always say assess your patient first, because you want to make sure what the monitor's showing it's true. Always start CPR. You have your crash cart. The code team's coming. Monitor is usually already going to be on them, but you want to put the one that's from the crash cart on them. Team leader should take charge. I know we talked yesterday, some of us in the ER, the one embedded tutor we had years ago, she said if trauma came in and it was her room, she would be the one in charge, or, of that patient. Others would help her, but she would be the one doing the stuff. So it just depends. Want to make sure they have IVs. Like I said, throw another one in. They'll probably be intubated. They need to have the drugs there. Ongoing assessment, of course. ABG's documentation is really big. You never know when that's going to go to court, and your name's going to be on there. So. Crash cart equipment. This is an older picture. I probably need a new one. The backboard. We only have one backboard in lab. We'll have two, mainly because there are two codes going at once next week, so it's going to get a little noisy in there, but that's the best we can do. Defibrillator. Of course, our works on our little monitor. We won't use the ones actually on the cart. Meds. There's Foley's in those drawers. Suction equipment, goggles, gloves, all that good stuff. Oxygen equipment. Usually respiratory has their own little box like up on top of it. You cannot look at them at the hospital because they are locked. After it's cracked open during a code, then it goes to pharmacy to get refilled, and they give you another one in the meantime. We was looking at that yesterday, some of us on the crash cart in the unit. So they usually are, most of them have pictures, and we could not find one on that, of what is inside the crash cart. These are our drugs. You went over these drugs. You should know these drugs. Amiodarone, epi-lidocaine. You don't see that much anymore. They used to use it quite a bit in codes, so you may hear of it now and then, but not too much. Adenosine, atropine, the epi, of course, for Brady's, asystole, all that. So you should know these drugs. So next week when you're review your rhythms in between now and next week, also with your cards, because as team leader, you have to tell us what rhythm it is. Different ways we're going to give the meds. Mainly it's going to be IV, could be central line, could be IO. I know, was it Abby that said they put one in one of your patients on the unit on the floor that day?
Yeah, we had a code and they put one in on our floor.
So that's pretty neat. Yeah, those are watch some of those videos. They're very intense. They even have like military guys doing it, and they're like screaming their heads off. Endotracheal tube, you don't see that too much, putting meds through there. Peripheral line is what you're going to see the most, and then they will do central line during a code. They'll put those in too. So these are your algorithms. Like I said, you have them for next week, so make sure you bring them with you, your cards. If you do forget, I do have extras. Just let me know. But that's all you're going to need, because that's all you're going to be doing is practicing that part. Then the next week, you'll need your book for your test. So this is your Tachy, your Brady, and your VFib pulseless VTAC. Therapeutic hypothermia. A lot of you guys said you enjoyed that discussion. It was a long one, but I thought it was very good. And who was telling me they seen somebody have that done the other day? I can't even remember now who I talked to. Mason, was it Mason? No. I don't remember. I actually found that discussion, that story. You know how when you fly on Southwest and they have those books in the airplane? I actually found that on one of my flights, and so I was able to download it when I got home, and that's a story I used. So I thought it was very interesting. But you are seeing it more and more, and that's good. It's good to use that. So we want to get them to a target temperature, right, to help with their neurological status. So post-cardiac arrest care is very important. We want to check blood sugar during the code. We want to know what's going on. That's our H's and T's. So we want to try to preserve what we can. You know, in that video you had a while back of the 2 cardiac arrests, you know, the guy made it because they started CPR early, and then they did the therapeutic hypothermia on him. So 2 responses: we want the patient to come out of this code situation. We want them to get awake, eventually be breathing on their own. We want to know what caused this arrest. You know, was it choking? Did all that come out and everything was okay? Is he doing better? So we want to know what's going on. We'll have the chest x-rays, listen to his heart and lungs. Another one is he's still intubated. Sometimes in the code you're going to say, hey, we've done all we can. We're going to send him on to ICU. Are they going to be able to get him off that vent? Again, it depends. What's happened with his respiratory, his ABGs. How bad is his cardiovascular? Did it put him into renal failure? You know, does he have GI problems because of it? And again, the neuro. So with complications of any systems, arrest could occur again, and that could make the prognosis poor. So it just, you know, you just don't know. Again, what caused it? Did we get him in time? Like that lady in that 2 code video, you know, he didn't know how long she'd been down. So you just don't know. No 2 cases are ever going to be alike. Waveform capnography. Remember we talked about that with ACLS. Inhale and exhale carbon dioxide. Right, so normal is 35 to 45. And I'm almost positive you're going to have that as a question on your ACLS written test too. And it's in your book too, all that. So, and when you do CPR, it'll show on the monitor, show that stuff for us if you're doing it right, if you're given the right waveform. Do we know our H's and T's? You should know those by now. And we will talk about them when you're team leader, you know, if we're waiting for the time to get more epi or whatever. This is when you say, okay, this is when you can bring your whole team in to discuss this part. You know, why do we think this happened according to our scenario? We may have to read it to you again, because a lot of times you're going to forget during all that. But that's okay. Was it drugs? You know, was it toxins? Was it hyperkalemia? You know, what happened? So, nursing diagnosis, again, almost the same ones: ineffective tissue perfusion, impaired spontaneous ventilation, spiritual distress for the patient and family, right? Disturbed thought process, and fear. You know, they're going to have fear. Not fear for you guys doing the code, because you will have that too, no matter how many you've been in. Teaching, we're going to teach them again risk factor reduction. Make sure they get any studies they need done afterwards, you know, like EKGs or labs. Risk and benefits if they need to get the ICD. Make sure they always carry a card with the medication. Know those early signs of cardiac arrest. And again, the CPR classes. And that's it for that one. I know we kind of went quick, but really it's not a lot of new material that you guys did not know, right? Yes, no, yes. Okay, let's do your review. What did I just do? I put it away. I'll grab it. And I will post the review too.